Hello, this is Dr. James Camp at Lee College in Baytown, Texas. Welcome to my lecture on body fluid balancing acts for anatomy and physiology semester. Okay, so now we know how water gets into your body and how it gets out. Let's move on to talking about what's in all of that water. And the first category we're going to talk about are the acid-base balances. First off, most people have had some introduction to acids and bases, but it's worth reminding ourselves really quickly what is an acid, what is a base, and what is pH. Well, to start with, water, as you know, is H2O. But water can split into H plus and OH minus. It does this at a rate of about 10 to the minus 7th. And if you take the 7 off of that, you get the pH rating for water, which is pH 7, perfectly neutral. But there are other things that can add more H plus to water, and those tend to make a solution more acidic. Okay, because they add more H plus, the 10 to the negative 7 becomes a 10 to the negative 6 or a 10 to the negative 2. And so you get numbers like pH 6 or pH 2, or all the way down to, you can, I suppose, have a pH 0. pH 2 is about stomach acid. pH 4 is about kitchen vinegar. And pH 6 are some rather weak or mild acids, like maybe citric acid or something like that. On the other hand, there are things that can take H plus away from water, or they can add more OH minus. These are going to make your solution more basic or more alkaline. Those words are sometimes used interchangeably. Since we're taking H plus away, our amount of H plus goes from 10 to the negative 7 to 10 to the negative 8 or 10 to the negative 14. Okay, so you can get pH numbers of 8 or pH numbers as low as 14. I mean, as high as 14. A pH 12 is a strongly basic cleaner, like the amount of NaOH found in certain household cleaners. pH 10 would be some slightly less basic household chemicals. Somewhere in the range from pH 8 to 10 is sodium bicarbonate, also known as baking soda, which is often used as a mild base for neutralizing various acids. Your body likes to maintain a pH right here on just on the basic side of neutral at 7.40. And plus or minus, as we said, 0.05. So really between 7.35 and 7.45. And you can see on the wide scale of pHs, that's a very, very narrow range. The way your body maintains that tight pH range between 7.35 and 7.45 is to use what we call buffer systems. Okay, a buffer system, when you have low pH, that is a very acidic solution, the buffer system will react by removing H plus from the system. when you have a very high pH, the buffer system will react by adding H plus to the system. And so we have three kinds of buffers in our body that work that way. Okay. One kind of buffer so we're going to remove acid or add acid. One kind of buffer is a chemical buffer. These add or remove H plus automatically through a process called chemical equilibrium. So if, for example, you have the carbonic acid bicarbonate system where H2CO3, which is carbonic acid, can shift to form H plus HCO3 minus, which is the acidic proton and bicarbonate. If there's too much H plus in the solution, it will just shift to the left to form more carbonic acid, and that removes H plus from the system. If there's not enough H plus in the system, then we can shift to the right to form some bicarbonate and release more H plus into the system. So it naturally buffers the pH. There's an even better buffer, that is the main buffer that is found in our blood, but there's an even better buffer that's found everywhere in your body that includes proteins. Because proteins have NH2 COOH backbones. That's an amino acid there, right? This can shift in one of two ways. It can release H plus by forming H2NCCOO minus plus H plus. So we can make the solution more acidic. We can also shift in the other direction and use up some H plus by making ourselves NH3 plus COOH. So the protein, every protein in your body acts as a buffer that can add at least one H plus to your body if you need it, or take one away from your blood if you need that. The chemical buffers have a limited capacity, okay? The amount of buffer chemical in your blood determines how much H plus it can absorb or add. But they work very, very quickly. They work on a time scale of seconds. So this is low capacity, but high speed. There's also a respiratory buffer, okay? This takes that basic carbonic acid bicarbonate plus H plus buffer that we have in our blood, and it adds or removes CO2 from that equation. And this works because CO2 plus water form more carbonic acid. So if you want to, if your blood has become too acidic, you can breathe out more CO2, and that will shift this whole equation to the left, which will remove acid from your body. If, on the other hand, your body is getting too basic, you can breathe out less CO2, and more CO2 means more carbonic acid, means more bicarbonate and H plus, and so your whole body gets more acidic. So by controlling your CO2 output, you can control your pH. Again, breathing out more CO2 means your body gets more basic. Keeping CO2 in your body means your body gets more acidic. This has a medium capacity because there's only so much you can do to control how much CO2 you can breathe in and breathe out. You do have to breathe out some amount of CO2 all the time. And it has a medium speed because all of the blood in your body travels through your lungs once every minute or so. But it still takes at least a minute to get all of that acidic blood through the lungs. And so the respiratory buffer works on while the chemical buffers work on a time scale of seconds, the respiratory buffer works on a time scale of minutes. So it's a medium speed. Finally, the urinary buffer. In the urinary buffer, the distal convoluted tubule of the kidney adds or removes H plus and bicarbonate in opposite directions. So if your blood is too low in pH, it's got too much acid, then the DCT is going to reabsorb HCO3 minus and it's going to secrete H plus. On the other hand, if you have high pH blood, you're too basic, then you're going to reabsorb H plus and secrete HCO3 minus. The urinary buffer has a very high capacity because there's really no limit to how much H plus you can secrete in your, there's really no limit to how much H plus you can secrete in your urine or retain. But it has a very low speed because it takes hours for all of the blood in the body to circulate through the kidneys. Chemical buffers, again, work on a time scale of seconds, respiratory on a time scale of minutes, urinary buffer works on a time scale of hours, but it's a more permanent solution to the problem. This shows a couple of the common chemical buffering systems. Within your cells, we use phosphate buffers. In cells, tissues, and blood, you can find protein buffers, and in the blood itself, you tend to find the primary buffer is the bicarbonate system. This diagram compares the other two buffering systems, the higher capacity buffers. The respiratory system works within minutes by increasing or decreasing the amount of CO2 that you breathe in and out. The kidney buffer system, the urinary buffer system, works within a time scale of hours to days by slowly but permanently removing excess H plus or reabsorbing H plus in the kidney tubules. Okay. I like to bring in clinical information once in a while. There are two types of acid-base imbalances. Okay, they can be respiratory, meaning that it's a malfunctioning of your lungs that's leading to too much or too little CO2 in your body. Or they can be metabolic, meaning it's a malfunction of something in your digestive system or your metabolism of what you digest that's leading to too much H plus or too much bicarbonate in your system. Respiratory, and then the acid-base imbalances also can be either acidosis, meaning that your blood and therefore your body is too acidic, or it can be alkalosis, meaning your blood and therefore the rest of your body is too basic. So respiratory acidosis is a buildup of CO2 in your blood. a buildup of CO2 in your blood that leads to, what would CO2 do? It's going to make your body more acidic, so it's going to decrease the pH. This is, if there's a buildup of CO2, that's likely due to hypoventilation, often from some sort of pulmonary disease. For example, asthma can often lead to respiratory acidosis. Alkalosis means that you've depleted the CO2 in your body, in your blood. With less CO2, your blood becomes more basic, which means you increase the pH. This is often due to hyperventilation, which is often due to some sort of stress on your body. You hyperventilate when you're stressed out. The other option is a metabolic disorder. Metabolic acidosis leads to, or acidosis is from depleted HCO3 minus in your body. Okay, you have less base, so you have more acid, so that's a decrease in your pH. This could be digestive, okay? If you have diarrhea, if you have nutrient starvation, if you drink a lot of alcohol, all of those things can remove bicarbonate from your body. It could also be regulatory, a failure of the kidneys, or perhaps even something longer term like diabetes can lead to metabolic acidosis. Alkalosis, on the other hand, is a buildup of HCO3 minus in the blood. If you've got more base, you're going to have a higher pH. That's often due to conditions that remove too much acid from the body, like vomiting or diuresis, or due to antacid overuse, too much base coming into your body. It can also be an adrenal tumor situation. Finally, I want you to note at the bottom here, in each case, the other system tends to compensate. So if you have respiratory acidosis, the metabolic system is going to tend toward alkalosis to try to balance that out. Okay, now again, I want to encourage you to pause your video here and see if you can work through this. Figure out whether patient A has respiratory or metabolic acidosis or alkalosis, and what you think their next steps might be, and then try again for patient B. Okay, patient A has a pH of 7.2. That's outside the normal range, and that indicates a type of acidosis. So it's going to be either respiratory or metabolic acidosis, but we have to figure out which one. So we look at the PCO2. 35 is low, but it's still in the normal range. Okay. Then we look at the bicarbonate. 19 is very low. It's below the 22 over here. So patient A would be diagnosed with metabolic acidosis. That could mean that the patient is losing bicarbonate through a metabolic condition. It could mean they have some sort of diarrhea, or it could mean that they have a condition like a longer-term metabolic condition like diabetes. So the next steps in this case would obviously be some kind of metabolic workup, some blood tests to try to figure out what might be going wrong with the patient's body, with their metabolism. Okay, what about patient B? 7.3 is again just a little bit low, but it's on the acid side. So patient B is either going to have respiratory acidosis or metabolic acidosis. So again, we need to check the gas analysis here. Patient B's PCO2 is 49. That's way high. Okay. But their bicarbonate is 25. That's also on the high end, but it's still in that 22 to 26 range. So we would say that patient B is suffering from respiratory acidosis. That's probably due to some sort of a obstructive respiratory disorder that's keeping too much CO2 inside the body. So the next steps there would be to do a pulmonary workup to try to figure out if something is wrong with the patient's breathing. All right. Finally, we're going to talk about electrolyte balances real briefly. There are 6 main electrolytes that must be present in narrowly defined concentration ranges for our body systems to work properly. Sodium, potassium, chloride, calcium, phosphate, and magnesium. Of these 3, sodium, potassium, and calcium are very tightly controlled by our body, and we're going to talk in the next couple of slides about how that happens. A few quick facts about sodium. You'll recall from A&P 1 that sodium plays a critical role in both neuron and muscle electrical events. And you'll recall from this class that sodium plays a critical role in cardiac events. It sets the nodal cell pacemaker potential and is important in the cardiomyocyte action potential. A new idea that we introduced in this unit is that sodium is the main cation that contributes to osmotic pressure in the body. Osmotic pressure is the tendency of water to flow in a particular direction. And since sodium increases the osmotic pressure, it can be said that water follows sodium. So regulating total sodium in the body is not just about regulating your ability to do those electrical events. It's also about regulating interstitial fluid volume, blood plasma volume, and blood pressure. So sodium is probably the most tightly controlled of all of these electrolytes. Regardless of hormonal control, you may remember that up to 90% of sodium is reabsorbed in the PCT and the nephron loop without any control at all. That just happens automatically. So what we have control over is the remaining 10% of sodium. We can control 10% of the sodium in our blood every time it passes through the kidney. The hormone aldosterone influences the DCT, the distal convoluted tubule, and the collecting duct as well, to reabsorb more sodium, up to 99+%. It's estimated that you can get very close to 100% reabsorption of sodium under aldosterone. It increases blood volume and increases blood pressure as well. Aldosterone is very important in fighting a condition called hypovolemic shock, where a patient has lost blood volume and therefore lost blood pressure and therefore is going into systemic shock. Of interesting note, estrogen hormones mimic aldosterone, which is why women retain water during some parts of the menstrual cycle and some portions of pregnancy. Progesterone, though, has the opposite effect, acting as a mild diuretic, which is again why during some parts of the menstrual period and some parts of pregnancy, women find that they feel as if they're on a diuretic. Glucocorticoids in high levels can also lead to water retention edema, which is why glucocorticoids, as we'll learn in the next chapter, are very important stress hormones. And that's why prolonged stress can lead people to feel edemic and bloated and to retain water. Okay. The opposite of aldosterone is atrial natriuretic peptide. As the name suggests, natrium, or sodium, comes out in the urine. So ANP blocks the DCT and collecting duct from reabsorbing sodium, which means more sodium goes out in the urine, more water goes out in the urine following sodium, and so we're decreasing the blood volume and the pressure. But again, remember that we can only do that about 10% at a time. So we can slowly bleed sodium out of your body or urinate sodium out of your body if you eat too much. But if you're in the habit of having a whole McDonald's large fries every day, full of salt, your kidneys may not be able to keep up with that amount of salt intake. Finally, what happens if sodium is out of whack? Some imbalances of sodium include hypernatremia, which is caused by severe dehydration and excessive sodium chloride intake. Hypernatremia causes thirst and dehydration of the central nervous system, which can lead to confusion or even coma. And it leads to neuromuscular twitching and convulsions. Hyponatremia, a lack of sodium in the body, can be caused by anything that causes fluid loss, or it can be caused by water buildup. That is, taking in too much water can decrease the effective concentration of sodium. It can be caused by renal disease, excess antidiuretic hormone, or deficient aldosterone. So there are some hormonal disorders that can cause that as well. There are also some medications that increase the rate at which your body secretes sodium, and so you have to be careful with those to stay not just well hydrated, but to keep a reasonable intake of sodium at the same time. Gatorade works well for that. Hyponatremia causes neurologic dysfunction and confusion, much like hypernatremia. It causes muscular twitching and irritability and convulsions. And in extreme cases, it can cause that hypovolemic low blood pressure shock we were just talking about. What about potassium? Potassium is in many ways the opposite of sodium in the body. Potassium, when sodium is supposed to be outside cells, potassium is supposed to be inside the cells. Potassium plays a critical role in neuron and muscle electrical events in the repolarization stage. And we find that too little potassium outside these cells causes them to become non-responsive. Too much causes them to depolarize too quickly. You learned in this class that potassium plays a critical role in cardiac events, repolarization, and plateau potentials. And we find that either too much or too little potassium around the heart can lead to sudden death from cardiac arrest. Finally, a new idea, potassium counters H+ movement as part of the body's buffer system. Whenever the body wants to move H+ somewhere, it has to counter that electrical positive charge by moving potassium in the opposite direction. So having too much potassium leads to acidosis, and too little leads to alkalosis. And the reverse is also true. Acidosis can lead to hyperkalemia, and alkalosis can lead to hypokalemia. Again, you'll recall that 70 to 90% of potassium is reabsorbed in the PCT and the nephron loop without any control mechanism at all. So the body generally doesn't have a problem keeping its potassium. The general problem is that the potassium is supposed to stay inside your cells. It's not supposed to be in the blood at very high levels. So most of the time, we're more interested in getting rid of potassium if it's in the blood than keeping it. In general, the DCT and the collecting duct are programmed to secrete potassium into the filtrate. In times of low serum potassium, kidney cells naturally decrease their secretion. In times of low pH, kidney cells can reabsorb potassium. So it is possible to reabsorb or at least decrease secretion of potassium if your body is in potassium starvation. But it's important to note that the kidneys are pre-programmed to get rid of potassium, not conserve it. So it's important to have enough potassium in your diet that your body doesn't have to try to conserve potassium. Finally, in cases where your body really has an increased plasma potassium level, it will secrete the hormone aldosterone. Aldosterone, as you recall, is also part of the renin-angiotensin-aldosterone system for maintaining blood pressure. But aldosterone can also function purely as part of a negative feedback loop to decrease plasma concentration, of plasma potassium concentration. Imbalances of potassium are very similar to, in effect, to those of sodium, but with the additional problem that hyperkalemia can cause cardiac arrest, and can even cause flaccid paralysis of your muscles, keep your muscles from contracting. So that's why our body wants to get rid of potassium as much as it can. Finally, we want to talk briefly about calcium. You'll probably remember from A&P1 that most of the body's calcium, about 99% of it, is tied up in the bone as hard calcium phosphate crystals. Hypocalcemia, too little calcium in the blood, causes the body to start removing calcium from the bones. And so a long-term hypocalcemia can lead to osteopenia or eventually even osteoporosis. You'll also recall from A&P1 that calcium plays an important role in neuromuscular excitation. And we find that hypocalcemia causes muscles to go into tetany, and hypercalcemia inhibits nerves and muscles from working at all. And finally, you'll recall from this class that calcium plays an important role in cardiac action potentials and in blood clotting. So hypocalcemia can lead to clotting problems. Hypercalcemia can cause dangerous cardiac arrhythmias. So how do we keep calcium where it's supposed to be? The more dangerous problem is not having enough calcium. So our main hormone that regulates this is parathyroid hormone. PTH stimulates the distal convoluted tubule to reabsorb up to 98% of calcium in response to a decreased plasma calcium concentration. If PTH is not around, some amount of calcium is lost in the urine, and blood calcium levels will slowly fall on their own without any hormonal input. Finally, imbalances of calcium are going to look a lot like the hyper and hyponatremia and kalemia that we talked about, in that there's going to be neuromuscular problems, cardiac problems, skeletal muscle problems, though the problem with hypercalcemia tends to be more of a weakness in skeletal muscles than a tremors or anything, and the central nervous symptoms. One of the differences here is that you have the possibility of kidney stones with calcium. Hypercalcemia can lead to calcification of a lot of your tissues. Some of your soft tissues can start hardening with calcium crystals. But that's most noticeable when the calcium crystals form in your kidneys and therefore become kidney stones. Hypocalcemia, again, neuromuscular symptoms, muscle symptoms, and heart symptoms. But here we have the problem of low bone density and increased fractures as well. As your body tries to pull calcium out of your bones, it leads to low bone strength and an increased fracture rate. All right, and that ends our discussion of body fluid balances. I'll see you in class to talk about the endocrine system.